So next is the cholinereceptors, or we can call them acetylcholine receptors, or we can call them cholinergic receptors. These are the receptors. Why we are talking about it differently for a reason, because you have to know that there is not only one type of receptor present in all the different systems of the body or in all muscles. Different muscles and different parts secrete receptors that acetylcholine binds to elicit different response. But the purpose of it is just contraction, but it's just that the receptors are different. So we call them cholinereceptors. Now don't forget, we have two types of cholinereceptors or cholinergic receptors. The first one is the muscarinic receptor, and the second one is what nicotinic receptor. Don't forget, we have what muscarinic receptor, and we have what nicotinic receptor. Now, muscarinic receptor is a G coupled protein receptor, specifically a G receptor, while nicotinic receptor is a ligand-gated channel ion receptor. So the ligand-gated channel means that the neurotransmitter is acetylcholine binding to the receptor for the opening of the ion-gated channel. But when the G coupling protein receptor, its work is for what? Phosphorylation and also calcium release. Don't forget. Now, for the muscarinic receptor the muscarinic receptor is very, very important because it is stimulated by muscarine. Don't forget. The muscarinic receptor is stimulated by muscarine, and also so many drugs can stimulate this, and it can be inhibited by atropine. So atropine is an anticholinergic drug that can inhibit what? Muscarinic receptors. So because we would be talking about anti-muscarinic agent, or we can call them anticholinergic agent in my subsequent video. So how many muscarinic receptor do we have? So we have 5 types of receptor. So we have the M1, M2, M3, M4, M5. Don't forget, we have M1, M2, M3, M4, M5 receptor. So don't forget. So majorly the one that is useful really is M1 to M3. I get it now. M1 to M3 is very, very useful. But M1, M3, M5 have the same function, and they usually bind in the same place, and they produce the same action, while M2 and M4 produce the same action. So when you remember M1, M3, M5, the same thing. M2, M4, the same thing. Don't forget. So but specifically we'll be picking M1, M2, M3. So when you know M1 and M3, you also know that it's M5, but usually M4, M5 are not usually functional, and they are not present in some cells. Only M1 to M3. So but when I give you M1, M3, you know it's M5, and when I give you M2, you know it's also M4. So now first of all, start by the location of M1. So where can you find M1? You can find M1 first of all in what? Autonomic ganglia. Don't forget, you can find them in autonomic ganglia, because I told you that autonomic ganglia are present in both parasympathetic and sympathetic. You can also find them in gastric glands. Gastric gland contains what? Parietal exotic cells. They also contain Chief cells. They also contain endocrine cells. They also contain mucous neck cells. So these are gastric glands, and their purpose is that they secrete HCl, pepsinogen, mucus. So gastric gland, but specifically here, for the purpose of this lecture, I'll be picking what? The parietal cell, which secrete what? HCl. Don't forget. So you can also find the M1 receptor there, and also you can find it in what? Enteric nervous system. The enteric nervous system is the third part of the nervous system that is just there. We call it the local nervous system. So you can see M1 receptor in all this space, and the purpose here is that they help to what? Release what? Histamine. Histamine is secreted majorly. Histamine and HCl, they are secreted majorly by the gastric glands. Don't forget. Then the enteric nervous system is secreting mainly intestinal secretion. Also, you can also need them for what? The learning, memory, motor action, using what? The autonomic ganglia. Don't forget. Now the next thing, now in this place, now what is the nature of the neurons? What receptor do they bind to? They bind to the GQ receptor. Don't forget, they bind to the GQ receptor. They can be found in autonomic ganglia, gastric glands, and the enteric nervous system. Don't forget. And the receptor they mimic is what? The GQ receptor. So the GQ receptor is very, very important because it also shares the same receptor with M3. M3 also GQ receptor, but the difference between M1 and M3 is just where they are found. Now, if they bind to GQ receptor, what second messenger will they be giving? They'll be giving the what? IP3 messenger, which is what? Inosino triphosphate. Inosino or inosino triphosphate. They give what? Inosino triphosphate. IP3 or DAG, diacetyl glycerol. That is second messenger, because if you bind to GQ receptor, the first thing what you stimulate what we call phospholipase C. When you stimulate phospholipase C we hydrolyze what? PIP2. What is PIP2? Phosphoinositol diphosphate. Don't forget, phosphorinositol what? Diphosphate. So don't forget, first of all, once we bind to GQ receptor, we are stimulating what? Phospholipase C. So phospholipase C we hydrolyze what? PIP2. PIP2 now we form what? Or we stimulate what? IP3 and DAG. Don't forget. Now once you stimulate IP3 and DAG, what is the work of what? IP3? IP3 what? Enters the smooth muscle to stimulate what? The increase of calcium. So when you bring out calcium will now bind to camodulin for the purpose of contraction. Don't forget. So now, M1 can be activated by what? Oxytimorin. So oxytimorin is an agent that can what? Activate or that can promote what? M1 receptor. And they can be inhibited by perizepine. You can either be inhibited by perizepine or telizepine. Perizepine or telizepine. Don't forget. Now moving to the next one, let us look at the lookalike to M3 receptor. M3 receptor is the same thing. The GQ receptor, the same thing. Stimulate IP3 and DAG as the second messenger. They can be activated or promoted by beta-nicole. So beta-nicole is a direct cholinergic agonist. Or they can be inhibited by sulfenacin or derifenacin. So these are what? Cholinergic antagonists or anti-muscarinic agents. But the only difference here is that is where they are located. The M3 receptor here can be located in the bronchus. Now they can be located in the bronchus, majorly smooth muscles. The viscera and the bronchi was smooth muscles, one, where they cause contraction. They can be located also in the iris, where they constrict the pupil. Don't forget. They constrict the pupil by binding to the M3 receptor. They constrict the bronchus by also binding to the M3 receptor. Also, you can also see them in the vascular endothelium. So in the smooth muscles of the blood vessels, you can also see them where they release what? Nitric oxide. So when they release nitric oxide, what nitric oxide will do? Nitric oxide will what? Causes what? Vasodilation. The last one, you can also see them. You can see them in exocrine glands. Where are the endocrine glands? You can see them in the lacrimal glands. You can also see them in the what? The salivary glands and other exocrine glands. Don't forget. Now you can also gastric gland is also an exocrine gland. So exocrine gland can fall in the M1 or the M3 receptor, anyone. So I want you to get it. So oxytimorin for M1 is the activator. Beta-nicole is for the M3 receptor. Perizepine and telizepine, they are what? Inhibitor of M1 receptor, while sulfenacin and derifenacin are inhibitor of M3 receptor. M2 receptor now, where are they located? Their work is to inhibit. M1 and M3 is for contraction, M2 and M4 is for inhibition. So where are they binding first? You have to know that they bind to the GI receptor. So you either call it the GI or GO receptor. So when they bind to the GI or GO receptor, what do they do to them? They inhibit, they reduce the action of adenine cyclase and cyclic AMP. They reduce the reaction. So when you are inhibiting the phosphorylation, causing the phosphorylation, so plainly, when you bind to GS receptor, so because the G coupled protein receptor have three basic family, or they have three basic receptors. The first one is the GS receptor, G stimulatory receptor. You have the GQ receptor, which is G constriction receptor. That's how I know it. They contract. And you have the GI receptor, which inhibit the action of the GS receptor. So when you bind to GS, what do? You are what? You are inhibiting. So if GS can be phosphorylating, GI will be what? Dephosphorylating. And once you dephospholate, what happens? You are increasing the action of what? Hyperpolarization. So if you are causing hyperpolarization, you are increasing what? Potassium. So potassium will be entering into the what? Into the postsynaptic membrane. And when potassium enter, it will be decreasing contraction. So don't forget, your GI receptor is inhibiting both the GS and the GQ receptor by what? Hyperpolarization. And when you hyperpolarize, what happens? You are decreasing the action of contraction, causing what? Relaxation. And where can you find the M2 receptor? The M2 receptor is majorly, they are located first of all in the SA node. The SA node is present in the what? Heart, in the right atrium. So when they bind to the SA node, what happens? When acetylcholine bind to the M2 receptor in the SA node, they cause hyperpolarization, and hyperpolarization will decrease the heart rate. And when you decrease the heart rate, what do? You decrease the stroke volume, and plainly you decrease the cardiac output. Also, they bind to the AV node. When do they bind to the AV node? What happens? They decrease more and causes what synaptic delay, or they causes what AV nodal delay. Why? Because when you send impulses from the SA node to the AV node, there's a short delay. It happens about 0.1 seconds. Apart from 0.1 seconds, any more delay there can cause blockage. So where again they also bind to the ventricles and the atrium. So when they bind to the ventricles and the atrium, the contractile cells of these chambers causes what? Relaxation. So instead of them to contract to what? Push blood during systole, what happens? They start relaxing. So diastole continue occurring, and there's what? Relaxation. And when there's relaxation, there's no pumping of blood. When there's no pumping of blood, the cardiac output is what? Decreasing. Also, they are present in what? CNS. So when they are present in CNS, what happens? They cause what? Tremors. Don't forget, they cause tremors and what? Anesthesia. Don't forget, in the CNS they cause tremors and what? Anesthesia. Also in the visceral smooth muscle, when they bind to the visceral smooth muscle, they cause what? Contraction. Don't forget. Now, what are the agonists here? What promote or activate M2 receptor? The first thing that promote or activate M2 receptor is methacholine. So methacholine is also a direct cholinergic agonist. So same thing with beta-nicotinic. And what is the inhibitor here? The inhibitor here is tryptophan. You can call it tryptophan, or you can also use methyltryptamine. Don't forget, methyltryptamine can be used, or tryptophan can be used. It can be used to inhibit the M2 receptor, while methacholine can be used to activate the M2 receptor. Don't forget. Now the next receptor we'll be talking about is the nicotinic receptor. Don't forget, the nicotinic receptor, we said, is a ligand-gated ion channel receptor. And what is the uses of the nicotinic receptor? It allows the flowing of what? Ions. Why the muscarinic receptor can also cause their effect by what? Phosphorylation or dephosphorylation, or they can use what? Calcium. Don't forget. But for these people now, they allow ions to enter. So what are they activated by? Usually they can be activated by nicotine, but muscarinic receptor can be activated by muscarine, while nicotinic receptor can be activated by nicotine. But muscarinic receptor can be inhibited by atropine, which is an anti-muscarinic agent, while nicotine can be inhibited by tubocarin, or what? Hexamitonium. Don't forget, hexamitonium can be used here, or you can use what? Tubocarin. Don't forget. Now, what are the division of the nicotinic receptor? The nicotinic receptor have two types. You have the NM receptor and you have the NM receptor. Don't forget. The NM receptor is present in the neuromuscular junction, while the NM receptor is present in the autonomic ganglia. I told you that there's an autonomic ganglia here, but the autonomic ganglia present is the M1 receptor in the as the muscarinic receptor. So the muscarinic M1 receptor is present in the autonomic ganglia, while for the nicotinic receptor they are in the NN receptor. So the NM receptor is present in the neuromuscular junction, so we call it the neuromuscular receptor. Neuromuscular receptor because they are present in the neuromuscular junction, while the NN receptor is present in the autonomic ganglia. Don't forget. And now, what is the function? When acetylcholine binds to the NM receptor, what does it do? It causes depolarization, because presently the NM receptor is present in skeletal muscles. Don't forget, they are secreted by postsynaptic membrane of the skeletal muscle. So when the acetylcholine bind to the NM receptor, what happens? They causes what? Contraction. So first of all, when they bind, they open up the ion-gated channel for sodium to enter. Don't forget. But for the NN receptor, anytime you acetylcholine bind to the NN receptor, what happens? They cause depolarization. But now this autonomic ganglia are the relationship or the communication between the pre and postsynaptic membrane, or the pre and postsynaptic ganglion. So there's a preganglionic fiber and there's a proganglionic fiber. So the communication is what we call the autonomic ganglions. Don't forget. So now acetylcholine is released and bind to the receptor in the post-ganglionic fiber for what? The continuation of the transmission. So anytime, first of all, the preganglionic fiber is coming from the spinal cord directly. Don't forget, the preganglionic fiber is either coming from the brain or it's coming from the sacra. So when the preganglionic fiber is coming from there, what happens? They snapped on an autonomic ganglia, which is what? Receptors that form synapses. So when they snap there, what happened? The acetylcholine is released to the receptor on the postganglionic fiber. So when they really bind to the receptor, what happened? They elicit their response. But one thing you have to know, I told you that the preganglionic fiber innervate directly to the antennal medulla. So when it innervate directly to the antennal medulla, what happened? It releases what? Catecholamine. Don't forget. Now, also in the CNS, at either point, I told you, there are also cholinergic neurons in the CNS, and when they are released, what happens? They are present for cognition, they are present for learning, they are present for memories, and so all that stuff. But for the NM receptor, they are present in skeletal muscle, while for the NN receptor, they are present in autonomic ganglions. So now, one thing you have to know, both of them, they do the same thing. When they bind to the receptor, when acetylcholine bind to them, they open up the ion gated channel. But for the NM receptor, the two ions that communicate here, that inflow and outflow, is sodium and potassium. So sodium is entering while potassium is leaving. While for NN receptor, there are three ions that are communicating here, which is sodium, potassium, and calcium. Don't forget. Don't forget. Now, NM receptor, the NM, which we call the neuromuscular junction receptor, what happens? They are stimulated by what we call what? PTMA. What are PTMA? We call them phenyl what? Trimethyl what? Ammonium. Don't forget. PTMA is called phenyl trimethyl what? Ammonium. Don't forget. And they are what? Inhibited by tubocarins. I said this from the beginning. Tubocarins inhibit them while they are activated by PTMA. So PTMA is what? Phenyl what? Trimethyl what? Ammonium. Why the NN receptor? We call it neuronal receptor, which is present in autonomic ganglia. They are activated by DMPP. What are DMPP? DMPP is called what? Dimethyl what? Phenyl what? Piperazinium. Don't forget. DMPP. What is DMPP? Dimethylphenyl what? Piperazinium. That's what is activating the what? NN receptor. Why they are now blocked by what? Hexamitonium. So hexamitonium is blocking the NN receptor, while tubocarin is blocking the NM receptor. Now, phenyl trimethyl what? Ammonium is activating the NM receptor, while what? DMPP, which is what? Dimethyl what? Phenyl what? Piperazinium, is activating the NN receptor. Don't forget. So I hope it all made sense and you understood everything we have talked about the cholinergic receptor, or we call them the cholinereceptor, where we divide them into the nicotinic and muscarinic receptor. And we said the muscarinic receptor is subdivided into 5, M1 to M5. M1, M3, and M5 has the same function. Why? Because they bind to the GQ receptor for contraction, or they elicit response by producing calcium, while M2, M4 bind to GI receptor, we call it GO receptor, for the purpose of what? Inhibition. So they dephosphorylate, especially in the heart and the blood vessels. So we have talked about everything. So I hope you understood it. You could watch the video over and over again, and please start from the introduction to the autonomic nervous system. Then you go to cholinergic transmission, then you come to here, which is your cholinereceptors. So next we'll be talking about is the cholinergic drugs, which is the agonist itself. We're talking about the agonist, the specific drug themselves. We'll talk about them in the next video. So keep watching my video, like, subscribe, and share to everybody that needs this video. You get it now, so always do that. So I'll be seeing the next video here. Bye.